Hey, this is Dr. Hughes, aka Joel, coming at you from the annual meeting of the American Association of Cardiovascular and Pulmonary Rehabilitation. I gave a talk about dealing with depression in cardiac and pulmonary rehab, and it's about therapist scarcity versus antidepressant ambivalence. And it was a rapid fire talk, so I spoke for about 15 minutes and then we had a discussion, and then I summed up our discussion. And so I made a video out of it. I decided I would edit it together for you and take out most of the discussion that you can't really hear. And so this is probably going to be about 20 minutes long. I hope you enjoy it.
To this presentation, to make sure you're in the right spot, you should be at Dealing with Depression and Cardiopulmonary Rehabilitation, Antidepressant Ambivalence versus Therapist Scarcity. So if you're not in the right place, then see you later. I'd like to start by introducing our speaker. So Dr. Joel Hughes is a professor of psychology at Kent State University. He received his PhD in clinical psychology at The Ohio State University and a postdoctoral fellowship at Duke University Medical Center. Dr. Hughes is a licensed psychologist whose research focuses on psychosocial factors in heart disease. In particular, he and his colleagues at Case Western Reserve University and University Hospitals of Cleveland have conducted research in the area of depression and heart disease among patients in phase 2 cardiac rehabilitation and patients with heart failure. In 2009, he became a fellow of FAACVPR. So it's my pleasure to announce Dr. Hughes.
Thanks, Carly. Can everybody hear me okay? Okay. I can't tell you how impressed I am that so many people came out, because I know it's late on an afternoon and there's a lot of other more fun things you could be doing than talking about the enlightening and uplifting topic of depression. So I have no disclosures to report, other than that I am not a physician. And so one of my least favorite questions to get is, should I take an antidepressant? And I think I can shed some light on why that is today. So here's the problem. Depression is highly prevalent in cardiac and pulmonary rehabilitation. Everybody knows this, but the resources are scarce. There was a Cochrane review of psychosocial interventions for heart disease, for example, in 2004. It was updated in 2011. It was updated in 2017. And the conclusion so far is that it appears that little progress has been made in reducing the increased risk of mortality associated with depression in patients who have heart disease. Now, psychosocial interventions do reduce depression and improve quality of life, and it appears from some evidence, especially some very recent evidence, that in the context of cardiac rehab, a psychosocial intervention can improve risk of mortality. But generally speaking, it's been very hard to show a lot of progress in this area. And so at cardiac rehab and pulmonary rehab, depressed patients are most often referred out, which is about 34% of the time, from some data in 2008 by Bonnie Sanderson, or provided no mental health services, about 32% of the time, from the same data from Bonnie Sanderson. When she surveyed over 300 cardiac rehab programs, she found that 3% had a mental health professional assigned to their program, in other words, paid by their program in-house. So show of hands, how many of you at your cardiac or pulmonary rehabilitation site have a mental health professional that's assigned to your site? Okay, it's gotten better, but still, I'm not going to call that more than 10%. It's probably less than 10%. How many of you have a behavioral health service at your facility to which you can refer anyone that you want to? Okay, so that's a little bit better. How many of you refer people back to their primary care physician to get antidepressants? Yeah, there we go. So this is tough, because usually there's not a lot we can do for people. I volunteer at a local cardiac and pulmonary rehabilitation site, and I go and I triage people to see if they have some kind of clinically significant depression or anxiety disorder. If the staff identifies the patient and refers them to talk to me, then I go talk to them, but it's a triage. And so I always carry around 3 business cards. I've got my Kent State University business card to show them who I am. I have my University Hospitals medical card to show that I'm non-employee medical staff. So I do have clinical privileges, but I'm not an employee and I don't bill. I'm just seeing what's going on, and when they need more help, I refer them out. And I carry around my Kent Psychological Associates card. This is not Kent Eichenauer, this is Kent, Ohio. There's a local mental health agency that I can refer people to, but that's all I got. There's not even a psychiatry department in this community, rural, fairly under-resourced hospital. And so what that brings me to is this feeling of ambivalence What are we going to do with people? Resources for mental health, behavioral health are scarce, but I'm about to march through some data showing that the effectiveness of antidepressants is not as good as we would like. And that also does not take into account patient preference. When surveyed, patients generally would prefer to have talk therapy over antidepressant medication, it turns out. So let's go through this fairly quickly because this is a rapid fire session, which means I get to speak as fast as I want. No, what it means is we're going to discuss. And so have your discussion hats on because what I'd like to do is to crowdsource some solutions because we need to solve this problem that affects so many of our cardiac and pulmonary patients. And the system's not going to solve it for us. And so let's see what we can do together. So anyway, here's some data from earlier in this century. It's from the SAD Heart trial. And what I'm just going to draw your attention to is that when you give sertraline to patients who've had a heart attack, in all patients, it is not more effective than placebo. But if they have recurrent depression, then it was a little bit more effective than placebo. That's not great. In the CREATE, which is a Canadian trial, in the CREATE clinical trial of citalopram, that was superior to placebo in 12-week Hamilton depression scores with a mean difference of 3.3 points, which maybe is not that awesome. But it did work a little bit. And in the MINDED trial, which is from England, there was no differences observed between intervention with antidepressants and control groups in mean scores on the Beck Depression Inventory. And one thing I'll point out about this trial is that they were flexible because if someone wasn't responding to Zoloft, maybe they put them on citalopram, they would be flexible, but the idea was antidepressant treatment or no antidepressant treatment. This one had no results. And then, of course, what about the special cases? What about heart failure? And so now systolic heart failure is an indication for cardiac rehabilitation in many cases. And I'd like to draw your attention to two trials in particular that were trials of antidepressants in heart failure. This is the SAD Heart, congestive heart failure, same thing, sertraline. Look at this enormous drop-off in depression scores in the first 2 weeks. And then it's kind of the same line. So sertraline is not more effective than a placebo, but they both seem kind of effective. What's that about? Same thing happened in the Mood HF study, which is this is citalopram instead of Zoloft, or sertraline. And again, a huge drop off in 6 weeks in depression, and then it just kind of stays the same, and there's no difference between groups. And so at this point, for heart failure, which I know is a special condition and not all cardiac patients, there's no evidence that antidepressant treatment is better than placebo, which is difficult. Okay, let's look at chronic obstructive pulmonary disease, because this is cardiopulmonary rehabilitation, and there are many, many pulmonary patients who have, in my estimation, about a 100% chance of being anxious, and maybe a third are depressed, although it very much depends on the sample. So in the GOLD guidelines in 2017, there was no recommendations for antidepressants. And in 2018, they were able to sidestep the issue because what they said is there's no evidence that anxiety and depression should be treated differently in the presence of COPD. Okay, that's true that there's no evidence, but absence of evidence is not evidence that it's the same. That's not equivalence, that's just saying we don't know anything. Now, is there anything about chronic obstructive pulmonary disease that could affect how antidepressants work? I don't know. I asked somebody and they said that liver metabolism can either speed up or slow down the absorption and blood levels of antidepressants based on whether or not someone is smoking or has other physical complications. And so I don't think it's the case that it's going to for sure be the same to have COPD versus a otherwise healthy middle-aged adult. Their response to antidepressants may not be the same. And so, in the real-world settings, about a third of depressed patients with COPD are going to get antidepressants. And patients with COPD would prefer behavioral treatment. Just like heart patients, they would prefer a behavioral treatment to another pill. And it turns out that neither their depression nor their clinical condition is likely to be helped by antidepressant use alone. So that's bleak. And so here's all of the large randomized clinical trials of antidepressants for depression in the context of chronic obstructive pulmonary disease. I went and I followed the PRISMA guidelines, I did a systematic literature search. There aren't any. But here's one example of one study, this was in China, of 120. So that's not really large scale, but we can pretend it's large scale. They started the same in their Hamilton Depression score, and then in the sertraline group, they went down by 4.5 versus 2.1, and that is statistically significant. I don't know if that's clinically significant, so that's not much evidence in my view. And so, what are the options? Well, we can have behavioral mental health interventions, such as therapy or counseling, or we could give people antidepressant medication or some other pharmacological approach. And there's an interesting story there. Why are SSRIs called antidepressants? Because they also work for bulimia, generalized anxiety disorder, post-traumatic stress disorder. It's just history. The first thing that they noticed that they worked for was depression, so they called them antidepressants, but they're not antidepressants. That's actually a misleading term. What they are is things that change neurotransmitters in the brain medicine. And to be honest, for a long time people thought that you had a chemical imbalance, and so if we would increase the serotonin with the reuptake inhibitor, that would improve your depression. But if we reduce the, let's see, what is it? Oh yeah, selective serotonin reuptake enhancer is just as effective as a reuptake inhibitor. So whichever way you push serotonin, depression is reduced, which suggests to me that some of the effects of these medications are probably very complicated. We don't really know what they do. But we also know that they're associated with a number of psychological and behavioral events, such as, I have to take this medication every day, I'm trying to see if there's side effects, I'm on a schedule now, I'm monitoring my pill taking, I'm monitoring my depression. That is a behavioral intervention, and that is a self-management intervention. And we know that self-monitoring is the cornerstone of all behavioral interventions. And so I'm wondering if you can disentangle the behavioral element of a pharmacologic agent like this from the pure pharmacological effect. Because, and it certainly seems that the placebo responses are large. So anyway, so those are our options. We have behavioral mental health counseling, antidepressant medication, or some other pharmacological approach, or we can do combination. There are some studies suggesting that, at least in patients who are not in cardiac rehab, a combination of therapy and antidepressant use is more effective than either alone. Or we can do stepped care, which is to say, start with the least invasive option, and then if that doesn't work, add more. If that doesn't work, add more, and figure out what it's going to take for each patient for them to do better. Or we could consider cardiac and pulmonary rehabilitation to be the therapy, because that's also a behavioral multi-component intervention that is effective for depression, by the way. And it involves exercise, social support, psychoeducation, and this brings up the whole issue of you have combined an exercise treatment with a pharmacological treatment when you put someone on an antidepressant. And so that's not just solely, antidepressant by itself. So here's our discussion questions, and we have until 4:50. We have, what is that? 13? I don't know. We have some time. We have a little bit of time to discuss what is the mental health infrastructure at your site for cardiac and pulmonary rehabilitation? What is the reality in which you're living right now? What options do you even have? And does anyone know, what do your patients prefer? We know from some survey studies that have been done, but what about your patients? Do your patients want a counselor, a therapist, or is that too much work because they have to maybe drive around and stuff? Also, what treatment options do you typically choose if you're the person who can choose? Maybe you're not. Maybe you have to ask the patient what they want. But maybe if you have a limited set of options, what is it that you're recommending for people? What about this? Should you take a different approach? Is there anything we could be doing that would be better than what we're currently doing? And what could we be doing as a field to solve this problem that antidepressants are not as effective as we would like them to be, and yet there's not enough, there's 34 psychologists per 100,000 people in the United States. And that's all the psychologists. That's not the psychologists assigned to medical centers. And so we are under-resourced for mental health resources, and yet our patients are depressed, and this is bad for their outcomes. So these are our questions. Now is the time. We probably shouldn't use the mic, to be honest, because otherwise it would take too long. But why don't we start to discuss some of these questions? Who wants to go first? Go ahead.
So we recently invited the head of psychiatry to come to our department because we're seeing so many patients, as everyone in the room is, with depression.
And in the last couple minutes, I'm going to summarize some points. this discussion has given me some ideas. I don't know if you'll agree or disagree, but I'm just going to throw it out there. Number one, I think that the use of antidepressants has been and will continue to be very controversial. And so I remain ambivalent. I'm not a physician. It's not my place to tell a patient what to do with respect to antidepressants. And for some people, they just swear by them. Some people have more than one thing. They have, maybe bulimia and depression and anxiety disorder. Maybe it works great. And so there's a little bit of a patient choice that has to be taken into account, even though we know that they're only called antidepressants for historical precedent, that they don't fix the serotonin necessarily. I mean, there's a lot of issues, but I'd never say to someone you can't have antidepressants, because I'm not legally authorized to say that, and it's just a very controversial issue. Second of all, I think that we're going to need to systematically review the literature to date for cardiac and pulmonary rehabilitation in terms of if these patients are eligible in this clinical trial for cardiac or pulmonary rehabilitation, would the antidepressant work? And come up with some better evidence on whether or not your patients that you see could benefit or not. We just need to know where we are. And I've started that, but it's not done. And so I'd like to know where we're at so that you could have exact recommendations. Thirdly, I think we need to have better decision algorithms. And so if someone has a high score on the PHQ and I meet with them, half of the time they're fine. So maybe if we had a better way of deciding who's just going to benefit from rehab as therapy, and that's all they really need, and who is there's some red flags that they need to meet with somebody. Sometimes I'll meet with someone and it's clear to me that they're bipolar and I'm over my head. They need a psychiatrist immediately. And so there's sometimes we need a better decision algorithm for what to do with this patient, because some of them are okay. They're having maybe a more realistic reaction to the fact that they've had a major cardiac or pulmonary event and it's not fun right now, but they're going to be okay. And then fourthly, I think we need to come up with some simple and scalable treatments that maybe could be used at the master's level by maybe social workers who are frontline providers, or little pieces of elements of treatments that could just be put into your behavioral health part of the psychoeducation that you already are doing. Those tend to be individually created by cardiac rehab programs or downloaded from some website or whatever you were taught when you were in school. And I wonder if we just need better modules of things that we know are theoretically things that would work according to the literature, and then provide those to people. And then finally, fifthly, I think we need more resources. There's no way around the fact that both in cardiac and pulmonary rehab, on the rehab professional side and on the behavioral health side, we just need more resources, and we're going to have to continue to advocate for that. So does anyone have a final, we got just a tiny bit of time, does anyone have a final reaction to my summary that they'd like to share?